Moving on to the second lecture of the academic session, we have with us Dr. Sukesh C. Nair, Professor, Pathology and Hematology, Christian Medical College, Vellore. His topic is Bleeding Patient, Don't Make Things Easy for an Indemnity Lawyer by Poor Selection of Investigations. I would like to give a short introduction of Dr. Sukesh Nair. Dr. Sukesh C. Nair, his qualification is MD, DCP, DNB, FRCPA. Currently, he is the Professor of Department of Transfusion Medicine, Christian Medical College, Vellore. He is a part of working group of APTT clot waveform analysis under the F8 and F9 subcommittee in ISTH, that is International Society for Thrombosis and Hemostasis. Dr. Sukesh Nair has conducted hands-on vet workshops for ISTH and WFH in diagnosis of bleeding and thrombotic disorders in various corners in the world, including India, helping them develop ability towards laboratory management of bleeding and thrombotic disorders, and has been a resource person in the ISTH WFH training the trainers. He runs a proficiency testing in India in hemostasis and transfusion medicine. This program has helped and is helping EQAS, that is External Quality Assessment Scheme, in Philippines, China, Thailand, Sri Lanka, Egypt, and South Africa. He has 101 publications, mostly on hemostasis. He has developed the concept that cell counters identify morphological features of peripheral blood and more objectively than microscopes. His laboratory is a place of preference for candidates awarded training fellowships from WFH, ISTH, and ASH, that is American Society for Haematology. Ladies and gentlemen, presenting before you, Dr. Sukesh Nair.
Thank you very much. First of all, congratulations to Sandeep and Bhumi for such a fantastic center and providing services, hematology services in this region. Amazing, very proud of both of you. And of course, I've got Abhijit and both Abhijits and Gautami here. Again, proud of both of you. We all know this pathway. From MBBS, MD, we all studied the intrinsic and extrinsic pathway. So you see the pictures of these two gentlemen. The gentleman on top is Robert McFarlane. He gave us the extrinsic pathway. And the gentleman below who is collecting blood gave us the intrinsic pathway. And you know, the reason is that Robert McFarlane's father died of Russell's viper venom bite. And he realized that Russell's viper venom activates factor 10. So that's how he got into the extrinsic pathway. Now, the Oscar Ratnoff is collecting sample from a gentleman whose name is John Hageman. So Hageman is factor 12. And John Hageman did not have any factor 12. 1 week after this picture, John Hageman died of massive pulmonary embolism following a train accident. So rather than bleeding, he actually had thrombosis. So one of them called this was published in 1965, one in Science, one in Nature. One called it as waterfall hypothesis and the other one called it as cascade. So looking at this picture, you can guess which one was waterfall and which one is cascade. I also thought like you. So the intrinsic pathway was called the waterfall and extrinsic pathway was called the cascade. So I'll start with a 45-year-old lady who was referred by a famous cardiothoracic surgeon from Coimbatore because the preoperative APTT was very high, more than 100, like a hemophilic. So when they came to CMC also, the APTT or activated partial thromboplastin time was also high. The reference range was 27.8 to 36.5 and the patient had 113 seconds. So APTT is a time taken by a recalcified citrated plasma to clot in the presence of a negatively charged contact activator and phospholipid. So phospholipid is partial thromboplastin, that's why it's called activated partial thromboplastin time. And it basically starts with factor 12 and it traces through the intrinsic pathway. So it'll give you an idea about the intrinsic pathway, factor 12, 11, 9, 8, 10, 5, 2 and fibrinogen. Usual range is about 27 to 37 seconds, but when you put the results onto the patient's record, you should put the time obtained on the patient's plasma with the reference range. Prothrombin time is not like APTT. It is actually the time taken by recalcified citrated plasma to clot in the presence of tissue factor, tissue thromboplastin. So that activates factor 7. So it traces the extrinsic pathway through the common pathway. Again here, please report the time obtained in the patient plasma with the reference range. That is the standard requirement. So prolonged PT means it will be a deficiency of any of the extrinsic pathway factors. So what is the goals of pre-surgical hemostasis assessment? It is to discriminate between normality and pathological bleeding tendency. To differentiate a severe bleeder, it's not difficult because they will tell, I bled. But a mild bleeding disorder, how seriously should we go into a mild bleeding disorder? So I'll show you some examples. So what is the sequence of actions when you get a prolonged APTT? See, prolonged APTT, when we are talking about 113, it is basically the patient's problem. But there can be mildly prolonged APTT, like 45 seconds, 55 seconds. So there is a sequence. When you get that result, there is a sequence. The first thing is the preanalytical, because preanalytical is the most common cause for a prolonged APTT. Bad sample collection, time of analysis. So you must realize that sometimes sample collection, in fact, today when I was in the Siddhivinayak Cancer Center, I met the BMT nurse. I talked to her. I said, how do you collect sample? So she got very nervous. I said, doesn't matter. I'll come to you later. So, the evacuated tube system, Vacutainer, is the best system of sample collection. Not that the other systems are bad, but it is the best system because the blood is directly coming in touch with the anticoagulant. So risk of clot formation, risk of underfilling is absolutely zero. But if you use syringe and method and you open the cap and add the sample, you may compromise the integrity of the primary sample. So opening the cap means there's a chance that there can be a preanalytical error. Now, when you call the nurse and ask, did you collect the sample properly? What is the answer going to be? Obviously, I collected it. So, we realized there's no point in asking. So what we did was, we look at this tube, because, we have a closed system. So if the tube has got a red blood in it, that means it was collected properly. If it does not have red one, cap was opened, sample was added and sent to the lab. So that is an easy way to find out the preanalytical issue. So what are the screening tests for hemostasis? Platelet count, prothrombin time, and activated partial thromboplastin time. So this lady's PT was normal and platelet count was normal. So what next? Now that we know that it is truly abnormal time, we want to know the prolongation is because of something. So we do something called mixing studies. It's also called correction because we are trying to correct an abnormal time. Now, mixing study is the most important test in a lab, in a hospital which manages patients with bleeding. Without this test, it's better not to have a blood bank, because this will tell you whether the patient has got bad time because of factor deficiency or some inhibitor. So, rationale is if prolongation in time is because of factor deficiency, you mix normal plasma to the patient's plasma, it will supply the coagulation factor and the repeat time will be normal. But if suppose after mixing the time is still abnormal, that means there is something inhibiting the clotting. That is heparin. So there is no point in transfusing FFP. You have to give protamine. It could be an inhibitor or antibody to a factor. Then you need to contact the hematologist and look for bypass agents. But sometimes when you have an abnormal APTT, contact these fellows. They will correct everything for you. So mixing study was done on this lady and it was normal. So that means she has got a factor deficiency. So which factor? It has to be in the intrinsic pathway because APT was normal, so not common pathway. So we did factor assay. Factor 8 was 283, factor 9 was 175, factor 12 was normal, factor 11 was absent. She had severe deficiency of factor 11. In the old day, factor 11 deficiency used to be called as hemophilia C. So screening test for hemostasis again, we have discussed this, but there is the most important screening test for hemostasis. The most important, and that is history. This lady had no past history or present history of bleeding, 45 years, 2 full-term normal deliveries, the last one was 22 years back, and she never she never had bleeding, so she never required transfusion. So people may think that probably history taking is not good, but we have tools available, freely available, downloadable tools called bleeding assessment tool, which in the first column you can see all the symptoms are listed, and then along the row you can see the degree of the symptoms can be, like for example, it can be just a consultation, then the score is 2. If they did some intervention like giving tranexamic acid or doing some smaller procedure, score of 3. And if blood was transfused, score of 4. So you can go through all these symptoms and the depth of the intervention, and you can realize that if a bleeding score is more than 4 or more than 4 in a male, he is a bleeder. If it is more than 6 or 6 in a female who has menorrhagia as a symptom, who also has menorrhagia as a symptom, then it's significant. Otherwise, it is score of 4. And a child, it will be 3 or more than 3. And the negative predictive value of a score of less than 3 is 99.6%. So let's look at 2 cases. This 18-year-old female has, of course, she doesn't have any menorrhagia. So she has epistaxis and she was given tranexamic acid. So she will have this intervention, score of 3. She's an adult, 18-year-old female. Menorrhagia is not there, so the score of 4 is going to apply. But she has only got a score of 3. But she was referred to us to rule out mild von Willebrand's disease. So this type of patient, we will break our heads. We do a gamut of tests. Every test is going to be normal. Then we suspect, maybe that is, so we'll innovate some tests and do those tests, they are also normal. So finally we give the report, no intrinsic hemostatic defect. Actually the bleeding score had told us there is no intrinsic hemostatic defect, but still we do this. So if suppose there is menorrhagia, you can even quantify and objectively quantify the menorrhagia by what is known as pictorial bleeding assessment chart. So this is a 2-year-old boy who was, I think, post-traumatic injury, and he required suturing. So bleeding from minor wounds, surgical hemostasis 3. In a child, score of 3 and more than 3 is significant, and he was diagnosed to have mild von Willebrand's disease. So coming back to my patient, severe factor 11 deficiency. So if 11 deficiency, she has not bled, she doesn't have any factor 11, there must be some problem with the pathway. And we also know that factor 12, Haegemann died of thrombosis. And this lady with factor 11 deficiency does not bleed. But I have seen factor 11 deficiencies which bleed significantly, maybe even mild deficiencies. But there was one more problem. People we know who have hemophilia, they have severe bleeding. But why do they bleed when they have a normal extrinsic pathway? The clot can happen this way also. So then people started questioning it. So the answer started coming in early 80s. One is that tissue factor and factor 7 can activate factor 9 in addition to factor 10. And then they discovered a new protein which is being manipulated now called tissue factor pathway inhibitor. That is, this factor becomes active when factor 10A is produced from the extrinsic pathway, and then together it comes and blocks the extrinsic pathway. Now extrinsic pathway is not going to produce any thrombin. Gone. So they came out with a new theory called the cell-based theory of hemostasis. Three steps: initiation, amplification, propagation. So initiation is when injury, tissue factor is exposed, combines with factor 7, activates 9 and 10. This 10 will find a little bit of prothrombin nearby, convert that prothrombin to thrombin, but this thrombin is very little. It's not going to do much. But what it does is, it activates the platelets. And in the platelets, factor 5 is there, it activates a factor 5 to 5A. The von Willebrand's factor is there with factor 8, it will activate factor 8 to 8A. And it also brings anionic phospholipid on the surface to allow the formation of 2 enzyme complexes. The prothrombinase complex, because the substrate is prothrombin, 10ase complex because the substrate is factor 10. Now because of this enzyme complex, the coagulation steps now becomes 100,000 times more efficient and produces 100,000 molecules of thrombin. 100,000 molecules of thrombin is actually enough for any clot formation. But just because in case it is 90,000 molecules of thrombin, there is a assurance called propagation. The factor 11, which was also activated in the platelets, will activate factor 9. Then the 2 enzyme complex happens, and the clot will ensure that 100,000 molecules of thrombin are available. So this is, propagation is basically an assurance. Now if you look at it, these 3 steps are nothing but our old pathway only. Like initiation is nothing but the old extrinsic pathway with factor 9. Amplification nothing but the old common pathway with factor 8 and 9. And propagation is nothing but the intrinsic pathway, but no factor 12. So now we know why factor 12 is not involved in clotting. So you can say that there is no role for factor 12. Now if suppose the amplification produces 100,000 molecules of thrombin, or even 110,000 of molecules of thrombin, do we need the last step, propagation? We don't need it. So if suppose amplification ensures all thrombin is produced, we don't need factor 11. So you can say that if factor 11 is deficient, maybe it can bleed, maybe it not bleed. So there can be enough reason for factor 11 deficiency not bleeding. Then you look at the sheer importance of 8 and 9. If they are absent, no thrombin. And of course, cells help localize the clot formation. So then, if history alone was good, why not people take that guts to say, no history of bleeding, do surgery? Of course, inadequacy of history taking, unreliable patient, we can say that excuse. But there can be appreciation of the fact that certain bleeding disorders will not have history. They will only start bleeding when you put the knife. Usually mild factor 11 deficiency and factor 7 deficiency are notorious for that. If they are less than 20%, they can bleed. But they will not history of bleeding. And of course, there can be acquired bleeding disorders. But fortunately, acquired bleeding disorders will come with bad bruises and you can easily make that out. So coming back to this patient, you look at her factor 8 and factor 9. They are very high. This patient with this level of factor will be not producing 100,000 molecules. It will produce 200,000 molecules of thrombin. That's why she never required her factor 11. Never required her factor 11. So to make sure that we actually are not theoretically producing, we actually did a thrombin generation test and we showed that she was producing 200,000 molecules of thrombin. So that the report we send, we can even confidently say this patient will not bleed during surgery. And that's cardiothoracic surgery. It's an intensive surgery. So the surgeon got the report. He also was trained in Vellore. So what did he do next? He ordered 4 FFPs. We told that he will not bleed, but he ordered 4 FFPs. Now how did I get to know? Because the anesthetist called me, because she was also trained in Vellore. She said, should we give the FFPs before surgery and do this and do the ACT? They do a test because they give a whopping dose of heparin and activated clotting time. Should we do it, leave the FFP and then do the activated clotting time, or can we use this as a baseline? I said, please thaw the FFP and keep it. Don't transfuse it. You use the baseline as activated clotting time. The best judge of abnormal bleeding is that surgeon. Because surgeon has done so many bleeding, he will tell that today this patient is looking a bit oozy. I said, give FFP at that time. Don't give FFP. If the field is clear. So that is one lesson I learned from this patient. The surgeons are not looking at bleeders. They want a clear field. They just want a clear field. And this surgeon, the surgery was over, so she called me and said that we discarded the FFPs at the end of surgery. So to administer a BAT, it takes 20 minutes. So I'll just give you 3 scenarios. 75-year-old gentleman, he had his hemoglobin dropped after surgery, total hip replacement. Dropped from 12.8 to 8.9. Pre-op, there was a coagulation screen done. PT was slightly abnormal. The physician missed it. Because it's 12.9, 12. Chalta hai. We actually found that this gentleman was mild factor 7 deficiency. And who missed it? A hematologist. This gentleman is a hematologist's father. So I immediately contacted Dr. Vikram. I said, can you just give some recombinant factor 7A before he decides to give FFP? 55-year-old gentleman, again a drop of hemoglobin after a total hip replacement. Mild APTT prolongation, factor 11 was 21.3. Okay, transfusion, 2 units of blood transfusion was ordered. This is a 69-year-old lady, pre-op, there was no issues, hemoglobin dropped because THR is a surgery which has a lot of bleeding. She was also given 2 units of blood. If you look at the morbidity of these 3 patients, there was no difference. 2 had coagulopathy, but they very mildly bled. The surgeon had a clear field. And that is the most important thing. The surgeon needs a clear field. So, mild bleeding disorders like this, should we really aggressively try to chase before the surgery, or let them show the symptoms and do the treatment? Because treatment is not easy and not difficult. It's easily accessible. You can take your time to decide blood transfusion. Yes, give 2 blood transfusion. If you want to decide to give FFP, you can order the FFP from the blood bank. But there is no emergency. There is no hurry at all. So maybe, we can pick up a mild von Willebrand disease, but that will also behave like this. Just a mild ooze post-op, not intra-op. So can we find some simple way of getting a simple history and just do a PT and APTT which can pick up a mild factor 7 deficiency or a mild factor 11 deficiency. So like for example, you can have, क्या bleeding हुआ, कभी जिंदगी में कुछ bleeding हो रहा है? So he'll say, epistaxis, he'll declare, epistaxis. Bruises, he will declare. Menorrhagia, they will declare. Hematemesis, they declare. The symptoms you may have to ask, because they will not declare, is tooth socket bleeding, gum bleeding. And if they have, they will reveal it. Very simple. So you can just, maybe in 2 minutes or 1 minute, you can finish the bleeding history. Because a severe bleeder will tell you a lot of bleeding. Mild bleeders, you can miss a few symptoms, doesn't make a difference. BTCT. Skin bleeding time, we do. It's a very difficult test. In fact, it needs a lot of good skill. It is basically defined as a time taken by a standard skin wound to bleed. We use this particular device, a lancet. Gautami and Bhumi are also using the same device. So, when you are doing this, you have to stab confidently 3 times because it's a standard wound you have to create. Now, if the wound at the end of 30 seconds does not bleed like this, that means the bleeding time was not done correctly. At the end of 30 seconds, the blood should come out from the wound like that. If it doesn't come like that, that means your bleeding time was not done properly. But bleeding time we do only in patients who have history of bleeding. We are not doing bleeding time to find out whether the patient has got is a bleeder. Because pre-op bleeding time is a useless test. And literature is in thousands. You do Google, in fact a lawyer, indemnity lawyer will just put bleeding time and he'll get thousands of paper which will say it's a useless test. So in the absence of history of bleeding, bleeding time is not a predictor of a bleeder or a hemorrhage. A normal bleeding time does not exclude a possibility of a bleeder because it can be badly done. And bleeding time cannot be used reliably to identify patients who may have recently ingested aspirin or NSAIDs. So the best pre-operative screen to predict bleeding is a history and maybe a PT and APTT. So only if you have a history of bleeding, you do a bleeding time. In the absence of history of excessive bleeding, bleeding time fails as a screening test. Thousands of publications available. So here I'll show you bleeding time. See, as I said, you saw the first case, the bleeding score of 3. No intrinsic hemostatic defect. So this is the last data from November 22, 350 patients. We had 48 patients who had primary hemostatic disorder where we actually find bleeding time a useful test. So among the 350 patients, 155 did not have any bleeding. We call them as no intrinsic hemostatic defect. Skin bleeding time was normal in all of them. There was nobody who had an abnormal skin bleeding time, but 38 of them had significant bad score. You know what is the reason for that? No harmony in the practice among our physicians. Some people will transfuse blood, score of 4 ho gaya. Some people will tranexamic acid, score of 3 ho gaya. So this 38 bleeding score was significant because of unnecessary probably iatrogenic reason. But in the primary hemostatic disorders, the bad score was significant except for those who are less than 1 year because it's not a time for them to start developing symptoms. And skin bleeding time was abnormal in all of them. We don't do skin bleeding time in people less than 2. But all those on whom we did skin bleeding time who had primary hemostatic disorder was abnormal. CT clotting time obsolete test. Only useful if you have a hemotoxic snake venom bite. Otherwise, of no use. Hemophilia, yes, it will be abnormal. But the history, the hemophilia patient will tell, I have got hemarthrosis, I have got big swellings. So he will tell. History is enough. Now, patient factor. This is a lady, 22-year-old, has acute fatty liver of pregnancy, bleeding severely after delivery, 8 red cells, 8 FFPs, 21 cryos, 16 units of platelet. And after that, we somehow got to 12.1 prothrombin time, 28 APTT, 155 fibrinogen, 9.1 hemoglobin, and 65,000 platelet count. This is enough for a person to stop bleeding. But she was continuing to bleed. Now, pregnancy is a totally different physiology. During pregnancy, the fibrinogen, von Willebrand's factor, all the coagulation factors go up. Why do they go up? Because when the lady delivers, she has got a raw area of bleed, and these factors help the mother. These factors are there to help the mother and not the child. So most of the common cause of postpartum hemorrhage is uterine atony or surgical trauma, 80%. All the others, DIC and all, are not common. But in patients who have atonic PPH or trauma PPH, their PT and APT is always normal. Always normal. Only after the blood loss becomes more than 5 liters, then PT and APT starts becoming higher. But there are other impaired preconditions like acidosis, hypocalcemia, hematocrit, hypothermia. See, for example, if your hematocrit is less than 30 and the patient is oozing, and if you find out the hematocrit is less than 30, if you correct the hematocrit to 30, they will stop bleeding. Because the hematocrit allows the platelet to marginalize to the site of injury. So if you have a difficult bleeder who is oozing and hematocrit is low, get the hematocrit very fast to 30, the patient will stop bleeding. You may have experienced this. Hypothermia. Enzymes are all working at 37 degrees centigrade. Patient is hypothermic. And where are we doing the test? At 37 degrees centigrade. So when we are going to do the test, we are going to say, oh, patient coagulation theek hai. But if you tell me the temperature is 35 degrees, I will change the temperature of the coagulometer to 35, do the test, then I can reflect whether hypothermia is causing a problem in this patient. So this lady is continuing to bleed despite fairly normal coagulation. Then recent data has come that fibrinogen of less than 200 is the predictor for PPH either going to ICU or undergoing procedures like hysterectomy or ligation. Less than 200 is bad for the patient. So laboratory-based tests, there is a fibrinogen assay available, and it's most important assay in a hospital which manages pregnancy. You cannot have the fibrinogen less than 200. Unfortunately, guidelines on massive transfusion have come from trauma. In trauma, they say fibrinogen of 100 is enough. So if you aim for fibrinogen of 100, you are never going to stop the bleeding. And the shock packs are there. You give one pack cell, one FFP. So you must realize one thing, that in pregnancy, the coagulation factors, especially fibrinogen, comes down drastically. 600 can come down to 300 in matter of moment uterus starts contracting or the tone comes back, the fibrinogen drops from 600 to 300. So now if you're transfusing FFP will have about 150 fibrinogen. So you'll dilute the 300 to further. So if you give FFPs unmonitored, you're going to dilute the fibrinogen. And then you're not going to get the patient back. So please keep fibrinogen assay as a very important assay in any hospital that manages pregnancy. Fibrinogen of 200 and more has to be achieved. So this lady's fibrinogen was 155, that's why she was bleeding. She was given a full dose of cryoprecipitate and she stopped bleeding. The last case, patient factor. So this is a lady who stays in Darjeeling. She's on warfarin, young lady. She has to come down to Siliguri to get the INR checked. So she wrote me a mail that her INR is 4.42 and she's taking 2 milligrams. So I wrote that it's high. Have you been well? Are you taking any antibiotics? Has the mango season started in your place and are you having a lot of mangoes? Please reply to this. Then I said that you can skip that evening store and next day you can start again at 2 milligrams. So she responds to me telling that she's having 3 to 4 mangoes a day. And then she also wrote that she had a sore throat and one, patient factor is very important. One, physician started her antibiotics. And what happened to her? She had mild lower abdominal pain. Ultrasound showed a hemorrhagic cyst. Just imagine, without asking a history on the patient, he was started on antibiotics and that prolonged her INR to 4.42 and that was 4.42 when she checked it. It must have been higher than that. And that's why she had the bleed. So patient factors are very important. But then she also asked, should I not be eating mangoes? Because why did you ask that question? So there was a study that was done in Vadodara where they found that during the mango season, a person has 2 mangoes, INR goes higher. 4 mangoes, it goes more higher. 6 mangoes, it goes almost to 5. So they didn't know what was the answer. So we actually realized that in Vadodara, when you have 2 mangoes, you have lesser vegetables. If you have 6 mangoes, your vegetable dose will also come down. And vegetable is the main source of vitamin K. So I told that, thanks for your reply. INR is a bit high because of antibiotic. Now that it is stopped, you should be fine. Don't stop the medicine, continue 2 milligrams, no need to skip today. There is no problem with mangoes. But people usually having mangoes will decrease their vegetables. So please continue having the same vegetables along with the mangoes. So my guru has always said, hemostasis equals love. Everybody talks about it, but no one understands it. Thank you very much.
Thank you, Dr. Sukesh Nair, sir, for such a flawless and enriching academic presentation. If anyone has any questions.
Call back.
Call back, is it?
Call back. They say that get back the dabigatran. They say because of incidence of cancer.
Oh, is it?
Any?
I have no
Just
idea.
today the message.
Oh, is it? I have no idea. Sandeep, you have any information on that?
Not.
Abhijit's? No information.
Sir, for this newer anticoagulations, you recommend to start some tests like to monitor the efficacy, like whether the drugs are working or not, like the rivaroxaban, dabigatran, that we should offer or we should not offer.
No.
So it's not
Until unless there are some, see, 2 times I will measure is when the patient is bleeding on anticoagulation. That is the most important time I measure. Sometimes if they have, they are showing no response to, the thrombus is not budging, then they probably, you can check it out. But it's possible to do the assay if you have the particular calibrator in your lab. But even if it's a non-specific calibrator, anti-10A assay, you can pick up. And thing is, the rivaroxaban and all, anti-10A assay comes more than low molecular heparin, almost 2 and all.
Correct.
So it will be far above therapeutic.
But for routine work, it's
No,
not required.
no.
Okay. And for clopidogrel, aspirin, whether they're working or not, you
Yeah.
want to offer something like for
Yes,
them?
I think,
because cardiologists, neurologists, they use a lot of clopidogrel.
Cardiologist will never order a test. Neurologist will definitely order a test because he wants to know whether aspirin and clopidogrel is working. 60% of Indians don't respond to clopidogrel.
Correct.
So you have to either you start on ticagrelol or prasugrel, but if your patient is on double antiplatelet agents, it's a good idea to check. The cardiologist will say, "क्यों पैसा बर्बाद करना है? Anyway, double antiplatelet पे है," but neurologist will want to know. So they ask for it. Yeah, there are tests available. They're slightly on the expensive side, but it is, if you have an aggregometry, that's enough. You don't need all those big devices like Verify or anything like that.
Sukesh, can I ask one question?
Dr.
Yes.
Abhay Bhave, sir, is online.
Bhave.
He's
So Sukesh, I'm just thinking that if your title was how to prevent a lawyer from getting onto your back,
Yeah,
and you've got today patients who refuse to give a proper history,
yeah,
either because genuinely they may not have a history, or they might have a situation where they've got insurance later and they don't want to declare past history.
yeah.
As physicians, we face this. And it's not that as physicians we are not taking history. We ask detailed history, but the patients, if I can use the word, they are not good historians for various reasons.
Yeah.
In this situation, to prevent a lawyer from sitting on our back, what is the bare minimum investigations? I've understood from you, BT-CT may not be appropriate. A PT-PTT may be helpful.
Yes.
But in today's world, when a patient is going for surgery, he's anyway going to spend some amount of money.
Yes.
The surgeon will get away scot-free saying that, I'm just using my technical skills.
Yeah.
The physician will get stuck because he's the one who has said yes to the surgery. How do you protect the physician? Which is the standard battery of tests you'd recommend?
Fine. So thing is, PT and APT for sure, but for primary hemostasis, when it's actually surgery, primary hemostasis will not be that much of a impact on APT should cover. But if the hematocrit is fine, and I think there is not much of gum bleeds or anything like that, then probably just PT and APT and the history should be fine.
But then we are likely to miss some
Primary.
mild, like you said, mild hemophilic state.
That
Because
will,
see, today's world is very litigious.
Yes.
So the smallest of bleed and the physician is stuck.
Yes.
So, the physician will, just like a surgeon will do a number of tests before considering the patient fit surgically. So we also need a battery of tests, which we should do as bare minimum to see that the surgery is safe. I mean, they may come normal 90% of the time, but we want that 90% to be safe.
Yeah. Yeah. So thing is, mild hemophilia and mild von Willebrand's, I would say that APTT will help, but sometimes a type 2 von Willebrand's you could miss if the patient is hiding a history, because type 2 will have very good history, but you can miss from a PT and APTT. They will be normal. That will be my biggest worry, because type 2 bleeds quite badly.
And Sukesh, you come from a center where the PT-PT is highly standardized.
Yeah.
But other laboratories in other cities or smaller centers may not be able to do the PT-PT in the way that you would like them to do. The reagents may be out, they may be a bit off, the Levi-Jennings chart may not be good, the machines may not be well calibrated. So I have to account for all those things when I'm going in for a surgical event. And the patient need not do the test with me. They might prefer to do it at a center closer to the house and then come to the hospital for admission one night before, with the surgery being at 8 o'clock in the morning.
Yeah, but
So,
intraoperative you can do a PT and a PTT.
so what about TEG? I mean, would it be worth doing a TEG?
Proprietary equipment, I would not, yeah, TGT, TGT
No,
is good.
TEG,
Huh?
thromboelastogram.
Oh, thromboelastogram.
Tech.
Yeah, so
On table.
Yeah, so thing is, the problem with thromboelastogram is that in most of the centers, all the centers, they do intem, extem, and fiptem, which is the same as PT and APTT. So if PT and APTT is not going to pick up, TEG is not going to help. But if you do a modified TEG, that is a modified extem, then there's a good chance that you can pick up mild bleeding disorders.
But tech might be able to tell me more about platelet function, which PT-PT may not be able to tell.
That's right, yeah.
Okay. So there is nothing like a bare minimum test that our physicians can do just to be safe, in the court of law in case the patient bleeds. So there is no such thing.
No.
So is there any protection? Have you come across any cases where you've been called as an expert? What kind of protection do we get for not doing the test?
Yeah, most of the cases have been transfusion related, but not bleeding related. I'm sure Vikram may have been called for some bleeding related events, because they always call clinical hematologists, not laboratory hematologists.
Right. Has Vikram been asked? No.
I asked him, he said no.
No, okay. Right,
Fine.
right. Thanks, Sukesh. Thanks a lot.
Yeah. Sorry that we missed you.
No, I'm missing this whole event, but it's a pleasure to listen to you. Always.
Thank you then.
Thank you, Dr. Bave. Thank you, Dr. Sukesh sir, once again for your presentation. A big round of applause for Dr. Sukesh sir.